Hi, my name is Dan Fox, and I am here with Dr. Sunda Friedman TeBockhorst and Angelo Ciliberti. I hope I got that right, Angelo. And we are here to talk with you about understanding adult ADHD, the symptoms, diagnosis, and strategies. So I'm really happy to be here with these guys because they are experts, and we're going to just dive right into some of the basics. I don't know if you guys want me to just kind of lead off with this slide, or
lead away, Captain.
Nice.
One of the things I was thinking that maybe we should say is that it's wonderful if this can be a dialogue in any way, shape, or form. So if there are questions that people notice themselves having as we go through this, it would be great if those could pop up so that we can address people's thoughts, questions, concerns as they appear for them.
Yes, which we want to do. We want to make this as helpful as we can, for sure.
Absolutely. It's an evocative topic for a lot of people, so there's so much here to cover. So,
can we dig? I want to dig into the second one on this basics slide, because we had this conversation shortly before the webinar started around the idea that to have adult ADHD, you've had it as a child. You either were diagnosed with it or they somehow missed it, but it's not as if you had a sort of normal-brained childhood and then had ADHD evolved, even though I feel that way. And that's what I was talking to Angela about. How is that, like, it's not possible for me to get ADHD with a combination of like lack of sleep, too many children, and caffeine?
Well, I think you're bringing up a good point that it can be tricky to diagnose ADHD because there's so many different things that can look like it, from anxiety to depression to sleep disturbances to family problems. And any of those things are going to cause problems with our attention. But it's also possible, I think, for kids to have grown up in more progressive educational environments where there were a lot more movement or attention was dealt with differently. And then to all of a sudden find ourselves in a context as an adult that's more limiting. And because of that, then the symptoms might likely show up more or in starker contrast than they might have in the milieu of our childhood.
Okay. But
I think your point also goes to, it rather begs the question, right, of what is ADHD and why does it easily get mistaken for things like sleep deprivation or trauma or whatever. So maybe it's worth talking about that for a minute.
Yeah.
Right. So essentially we're talking about a difference in executive functioning. What does that mean, executive functioning, right? So sometimes what I talk about is executive functioning. So we're talking about the CEO of your brain, who sits way up in the front of your brain in the corner office, right? Who's supposed to be telling you, who's supposed to be directing the resources available to the organization, i.e. your brain, right? So it's supposed to be directing resources and saying, pay attention to this, do not pay attention to that, stop paying attention to that, change tasks, and allocating resources. And so other things other than ADD certainly can affect executive functioning, right? Like sleep deprivation, like mood disorders, like anxiety disorders, like trauma. So the fact that you have something that's affecting your executive functioning doesn't necessarily mean that you have ADD, but if you have ADD, it's affecting your executive function.
I think it's really well said. Yeah.
And what about the last piece? Because traditionally when I think of ADHD, I sort of see the like 9-year-old boy just totally wired. And now with this statistic, there's this idea that both men and women as adults get it equally. And I know for my own family, my daughter's got ADD, not the H kind, not the hyperactive. So I can see it in kids both ways. And I know it's just more kind of overt with boys sometimes acting out. But is that like, do you see that in adulthood, that's kind of affecting people across the genders equally?
I want to just real quickly pull out something you just said and highlight it. You said, I don't have the H kind.
Yeah.
Right. And so I just want to note that sometimes when we are talking about ADHD in writing, we actually put AD/HD because the H is kind of optional, right? Some people have the hyperactive variant, and some people have a deficit of attention without hyperactivity. So both things can happen. So I just wanted to pull that out and recognize that difference.
Yeah. So there's really two types. There's inattentive type and there's hyperactive type. But I think one of the important things you're speaking to, Dan, is that as we become adults, we actually see a reduction in hyperactivity in ADHD, and we see more just inattentive type styles of ADHD.
Cool. All right, let's see what our next slide has for us.
Oh, and I want to speak one more to the other point that you just made about gender.
Yes.
Right, which does it look different? Can there be differences in how it looks by gender? And the answer is yes. Right, so you're pointing out that there can be differences by age. That's certainly true. People tend to outgrow their symptoms of impulsivity and hyperactivity as they grow into adulthood while maintaining their symptoms of attention deficits. It's also true, for whatever reasons, and we could talk about this probably ad nauseum, that before adulthood, right, in childhood, little boys are much more likely to get hit with that H. And little girls are less likely overall to be diagnosed at all. And when they are diagnosed, they're much more likely to be diagnosed without the H. They're more likely to be the sitting and staring out the window kid. And I don't know that that necessarily holds into adulthood, because we tend to outgrow some of those things. But yes, there can be some gender differences.
Okay. And so I guess as I look at these signs of adult ADHD, a lot of these are around attention, right? There's not so much impulsivity, hyperactivity. It's that CEO of the brain that you're talking about, just having a hard time kind of managing the strategies of staying organized and prioritizing and switching from task to task.
Yes.
Well, and I definitely also think just the agitation that some of us who identify with ADHD can often feel, it can lead to impulsiveness. And I know at some point we'll probably get more into the physiology of ADD, ADHD, and some of what might lead to that. But impulsiveness is certainly, I think, could be on that list. I think it's also maybe helpful to speak to, and this is something I was hearing you address a bit, just the variances and all the different kind of signs and symptoms. And I think it's worth noting that really ADHD has become a catch-all for any number of different signs and symptoms of inattention and difficulty with executive functioning. And it can look so differently for different people that I think it's very possible in 10 to 15 years, especially with advances in neuroscience, what we now call ADHD, we might be finding 10 or 15 different variations of, which might also address why treatment options really vary from one person to another, why some people who have the diagnosis of ADHD find stimulants very helpful and other people don't. And so it could be like 150 years ago, everything was a cold, but now we know there's colds, there's flus, there's differences between viruses and bacteria. And hopefully our understanding of ADHD will just continue to evolve.
This is reminding me of the work of Daniel Amen, who has done about over 10,000 SPECT analyses of kids with ADHD. And a SPECT analysis is where you put a little dye or something in the blood so that you can watch the cerebral blood flow. And there's been 6 patterns that he's identified of all these 10,000 SPECT analyses over time. And each one of them, he says, has sort of a signature style in terms of what you want to do for nutrition or exercise or little cognitive behavioral strategies to manage your symptoms based on how it shows up in your brain analysis. So that's kind of the cutting edge. And that's Daniel Amen has a book out, Healing ADHD, and he's got clinics around the country if people want to dig into that further.
Oh, excellent reference.
Maybe it would help if you spelled that for them. Amen.
Amen, like amen. Maybe our BPS helper will just put up a little resource. I think he's got like the latest book. It's like the revised edition.
Oh, nice.
Yeah.
Okay.
We'll put Jen to work on that. All right. Up next, my favorite. Well, I don't know if this is my favorite, but this is some of the symptoms that I feel like, aren't sort of the medical stuff, but just the like, I'm feeling like frustrated, whatever, like my mind's wandering, I can't get stuff done. And I love this website for its like inclusiveness and supportive and like hey, like ADHD, like this doesn't have to be bad. There's some cool things about it. There's some ways to sort of work with your energy. And the website, I think, is a great support for us as adults because it has this community that is also like working through this and finding a way to have a functional life.
Mm-hmm. And taking it out of pathology, which is, I think, very important.
Yeah, and I would even go you one step further and say it's important not only not to over pathologize, but to recognize also that there are certain strengths inherent to this style of being in the world that it's equally, if not more important, to recognize, and we can talk more about that.
But can we talk more about that?
Let's talk more about that.
Because I think about this constantly with my daughter as she gets older in terms of what is going to be the directions and the strengths. How can we really like create a supportive environment or create strategies that are really complementing what she's good at and how her brain works?
Yeah. Yeah, I mean, I think it's really, so one of the strengths that I talk about with adults with ADD that they tend to overlook and not recognize as a strength is what we call hyperfocus sometimes, right? And so one of the things that I talk about with adults is I hate the label ADD because I consider it neither a deficit nor a disorder, right? It is a difference in attentional style, right? And so sometimes the way I talk about that is if there were attentional units, right? Like you get a certain number of attentional coins, right? You get the same number on average as other people, and then you spend them differently. It's not that you didn't get as many, it's that you spend them differently, right? So it's not a deficit. And if you were to graph, right, like on an XY axis, how a person without ADHD pays attention, it would look more like kind of a sinusoidal curve, right, like a sinus wave. Whereas if you were to graph how a person with ADD pays attention, it's going to look a lot more like mountains and valleys. And because the reason is because people without ADHD tend to have a hard time engaging and focusing and paying attention, but boy, when they do, they will be in the zone, right? So like you might live with somebody with ADD if ... When they finally get focused on something and it took them 2 hours to really get there, but now they get there, and if you walk in and interrupt them, they bite your head off because they are in the zone and they can't deal with distractions, right? That's hyper focus. And that can be a huge strength, right? People with ADD sometimes have a hard time getting started, and they sometimes have trouble with procrastination. But they can also pull it out at the last minute because they'll go into hyperfocus and knock out in 4 hours what it might take somebody without this style of being in the world 12 hours to do.
Yeah,
totally.
You know what I mean?
And have some sort of energy reserve that I feel like can be tapped into in a way that oftentimes, people without that kind of neural wiring just don't really go there or have habits and strategies that kind of rev themselves up to get a burst of work done.
Exactly.
Well, and I also think that people with ADD, ADHD are often highly, highly creative. And some of the agitation or frustration that can be inside the body or the mind of a person with this often kind of leads to some real creative breakthroughs, because that creative breakthrough is also what kind of floods our brains with dopamine and really kind of creates this burst of inspiration that I think often accompanies people with kind of the artistic types. So Tom Hartman back in the 90s, I think, wrote a book sort of shifting the paradigm of ADD and talking about it in terms of hunters and farmers and kind of looking at what might be neurotypical as being kind of a farmer mentality, but the ADD being more the hunter mentality of working kind of like Dr. Sunda's saying in bursts, and really where distractibility and hypervigilance is actually quite an asset for somebody who's occupying that location.
Cool. Okay.
And there are certain occupations, by the way, where ADD can be more of an asset than a liability. And there are certain occupations that tend to have high concentrations of people with ADDs because they provide a working style that is amenable to a kind of on or off way of focusing. So.
And you said Tom Huntington?
Tom Hartman.
Tom Hartman?
And I think he wrote a book in 1993, which maybe our helper can look at. I'm trying to remember the title of it. But then there's been a follow-up book called The Drummer and the Big Mountain, which is sort of like written by somebody who coaches people with ADD and tips and tricks for managing it. And it's really, I think, a very positive kind of reframe of this and kind of taking it out of a kind of pathology language.
So can we start looking at that distinction between what might be other issues going on and what might actually be ADHD, and how do we help people to figure out how to diagnose it, and really why is that important? Because I believe why it's important is that if you think it's something else and you're not dealing with ADHD, you're not going to resolve the issue. It's like the interventions aren't the same. So it's actually helpful to get to the bottom of this.
Yeah.
It might also be helpful. We've been at it for about 15 minutes now. And so for our late joiners, I didn't know if it might be helpful to let them know that they are talking with me, and I am Dr. Sunda Friedman TeBockhorst. And you are Dan Fox, and you are Angelo Ciliberti. And we are all members of Boulder Psychological Services, and here to talk about ADD. So
and you are more than invited to please chime in the chat box, and to let us know any thoughts, questions that might be coming up for you as we talk about some of these things. And I think this is a really rich piece, Dan, which is just how do we know it's ADD, ADHD, when if you consider 75% of mental health diagnoses could look in some part similar to ADD. But it's very easy in a way to overdiagnose it because I think that there's an idea that there's an easy fix, which is, oh, this is ADD, and if we just prescribe a stimulant, then that will address it. When I think in reality, a lot of us realize that's not the case quite frequently. And this is why I think people that really take diagnosing ADD, ADHD seriously, it often requires hours of evaluation, as well as talking with multiple people from the family, ideally, especially in adult situations. If I'm working with somebody who wonders about themselves having ADD, ADHD, I often want to speak with their spouse or their partner, because often they have a much clearer sense of what's happening for that person than the person who's just so in it themselves.
So if I'm like, I don't know, in adulthood, looking back on my college years or something and think, oh, like there was a time that I took Ritalin or Adderall to study and it was helpful, therefore I have an ADHD wiring? Or is that's a jump to, like, just because Ritalin or Adderall is useful for people, and I feel like this is like by the time we're adults, we've seen other people during high school or college kind of messing with it recreationally and saying like, oh, it helps, I must be ADHD. But that seems a little, I don't know, like we're jumping to a big conclusion. So what is it about that medication? And it's not a diagnosis tool, right? Like just because helps you focus.
Yeah.
I want to take just 1 minute. We've had a question on the screen for a couple minutes, which I'm going to address now. And that question is, could you post references to the Healing ADHD? We'll see if we can't post them in writing later, but here is the reference for those of you who have been hanging on for that. The title is Healing ADD, the breakthrough program that allows you to see and heal the 6 types of ADD. The author is Daniel G. Amen, A-M-E-N, M-D.
Okay. I think I got that part. And then we'll see from there.
Sorry.
No, we're good.
That was a great question.
Yeah. So back to just trying to figure out, like, with the medication, that's not a starting point, right? We need to backtrack and look more at our functionality. Or the dream, I think, is in a few years, we get to a place where there's a neurological testing process or something biological that we can look at so that there's less of a gray area.
Here's an analogy, right? If you are feeling sleepy and you drink coffee and then you don't feel as sleepy anymore, do you have narcolepsy?
I'm going to say no.
No, right? Because coffee has caffeine, which has physiological implications in the body, just like any other stimulant, including methylphenidate, which is what's in Ritalin or Adderall or some of the major ADD drugs have, right? The stimulant has physiological effects in bodies with and without ADHD. So we're getting a question, and we hear you, Bright Heart One, and we will be with you momentarily. So no, right? The fact that a substance with a known physiological impact on the body and its functioning has a physiological impact on the body and its functioning is not itself diagnostic in any way.
Okay. Okay.
I mean, from a diagnosis point of view, and Brightheart, it's nice to see you joining us, by the way. I actually know Brightheart. And I think that this just raises important pieces around diagnosis and how actually there's very little training, surprisingly, in diagnosis, I think, for mental health practitioners, but also even for physicians. It gets talked about quite often. So one of the dilemmas that we often face is that it's very easy to have a particular diagnosis that people sort of jump to. This is actually where I think psychological testing is so important to slow down that process and to really help tease apart what's happening. But I think it is quite common for people to either jump to bipolar or even to jump to ADD. When I'm sitting with a client that's really wondering about this, there's several things I'm often very curious about. I'm curious about their history with anxiety. I'm curious about their history with trauma. I'm curious about their history with sleep challenges and their history with depression. And those things I'm often wanting to run through first in my mind and check out with them before we just jump into a diagnosis of ADD. Because the dilemma is, if you go to that diagnosis and you start going down that track, there's often a whole wealth of information and things that this person has been trying to manage that then do not actually get addressed. It's just a label of ADD, and then there could be all of these other things that are really impacting their functioning and their well-being that we then skip over. So that's why I really think it's important that we take this diagnosis very carefully and thoughtfully.
I also want to point out, back to our earlier point about executive functioning, right, that if you have an anxiety disorder, that can certainly affect your executive functioning. If you have depression and some of the vegetative stuff that can go along with depression, it can certainly affect your executive functioning. Trauma can certainly affect certain aspects of executive functioning. So is it real that you might be experiencing troubles remembering things, or troubles organizing things, or troubles getting to places on time, and some of those other things? Absolutely. But if that's really happening because you have a mood disorder and we hit you with a stimulant, that could be a big problem.
It can make it worse.
It could potentially cause a real problem. Right. And so getting real specific about what is causing the problems with the memory or the focus or the organizing is really an important step. Because if Brightheart's question is bipolar diagnosis, is it true that bipolar diagnosis is a frequent misdiagnosis for ADHD? And certainly there are a number of things that sometimes get mistaken for ADHD, and there are certain clinical implications for that. And I think that's really important to not be careless or slapdash in approaching diagnosis.
So let's say I'm trying to figure this out for myself, like this week. Should I go to my primary care physician? Should I look for a psychologist or a psychotherapist that has experience? Like where's my lifeline? What do I want to seek out? Because I feel like when I think about my kids' diagnosis experience, we got some handouts from the primary care physician that were like, have the teachers and parents fill this out. They get back and go, oh, looks like it. Here, try some Ritalin. And I feel like you guys are saying that that's not the path forward, right? We shouldn't just go to the primary care physician, say, hey, I think I got this, and try some stimulant medication. But what do we do?
I mean, I think it's similar to facing any other kind of condition where I think it's helpful to see specialists. Like if you're having trouble breathing, sometimes I think it can be helpful to go to a general practitioner, but at some point you might also want to see a pulmonologist who can really be very clear and tease apart what's occurring. And so I think if it is a real concern that people have and they're really wondering about it, what my counsel would be to take this slowly. Be careful about jumping to any particular diagnosis, because we all know that having a label for something can feel good, actually. It can feel reassuring. Even if it's a hard diagnosis, just having a label for it can often quell our anxiety versus being in the uncertainty. But because diagnoses do have such a big impact, it's important to seek out people that really know and are skilled in teasing apart what we're working with, like a specialist.
Yes. And to your point, right, if you're having breathing troubles, you're likely to get different suggestions about both diagnosis and potential interventions if you go to one each of a primary care physician, an allergist, and a pulmonologist.
Right.
Right? These
Right.
people will do different diagnostic testing, and they will suggest different interventions.
Right.
And the same is true with ADD.
Sure.
Right. And another way to approach your question is, should I go to my physician, is to ask which, physicians are likely to be prepared to provide a certain type of intervention, which is medication. But that doesn't mean that's the only kind of intervention that might be useful to the individual in question. It's what they know to do, though. It's what they, it's what their background prepares them for.
Right.
So, and not that there aren't physicians who have other options that are helpful. There certainly are. But much the same way that the allergist and the pulmonologist might have a different perspective, the psychologist and the physician might have very different.
Right. Oh, so our next slide is one of my favorite signs of adult ADHD, right? This one focuses on the attention, that here we are at work and it's going to be hard to just have our frontal lobes stay on that. Can we speak to like what's going on neurologically if we're struggling with adult ADHD? Why is our CEO not able to just kind of stay on that? And a farther question I had when you, Sunda, were talking about how can't focus, can't get started, and then boom, can hyper focus. Is that true of any activity across the board, or are there sort of certain sweet spots like gaming or some sort of repetitive computer thing where we can hyper focus, but other tasks that somehow, I don't know, are like more emotionally stressful or something, no matter what, it's going to be hard to focus?
Yes and no. I mean, right, one of the diagnostic questions that we ask when we're doing an ADD workup diagnostically is the deficit or the difficulty global? Mm-hmm. Or is the child just not like math? Mm-hmm. Or does the adult just not like writing reports? Right? Right. Right. That's not an attention deficit, that's a motivation problem. Mm-hmm. And so if we are seeing highly selective applications of motivation or ability or willingness to focus, that's kind of diagnostically relevant. Mm-hmm. Because ADD is, if you truly have this difference in attentional style, you have it across settings. Right? It's not on one time and off another time.
Okay.
On the other hand, we all have varying levels of motivation regarding different activities in our life, right? Mm-hmm. We are all more likely to avoid an activity that we find tiresome or boring than we are to engage in an activity that we find highly rewarding and engaging. Everybody does that. Right? That's not ADD. On the other hand, there are some people, your example of video games, right? If you've got a kid who hyper focuses and doesn't hear you talking to them and forgets to eat and forgets to go to bed because they get so engrossed in their book or their video game, that might also be diagnostically relevant.
Mm-hmm. And if we do that as adults, what if it's like a newer thing? What if as a kid we weren't like into that so much, but now it's like hyper focus on something? We can't count that, right? That's something else because it didn't show up in childhood.
Which didn't show up, the interest?
The hyper, like if I'm suddenly now like, oh my gosh, I love social media, I love gaming, but I didn't do that as a kid.
No. In fact, here's a great thing. It's obviously not a clinical question, right? In our sure. graduate school, how to diagnose ADD, they don't teach us this question, right? But ask a person, how many books are you reading right now? Right? Okay. Because one of the tendencies of people with ADD is to start lots of things, right? To impulsively start a thing because it grabbed my attention and it looked really fun in the moment and I started. And then when I changed activities, ADD brain does not like to change activities. Mm-hmm. It doesn't. It likes to, once it's in a groove, it likes to keep going. But okay, so I changed activities. Did I ever get back to the activity? Right? Mm-hmm. It's more, the answer to that question with somebody with ADD is more likely to be no, I never got back. So how many books are you reading right now? 12. Mm-hmm. Yeah. I like them all. Yeah. Right. Whereas people without ADD are more likely to say 1 or 2. That's right. I'm reading my fun book and my serious book or whatever. Yeah. But they don't have trouble putting it down and coming back. So actually, a tendency to get engaged in new interests on a very regular basis might actually go towards ADD.
Mm-hmm.
I don't know if that made any sense, but
we did have a question come through, and then I think it would be good to get back to some of the competing theories about what's happening neurologically. But let's see. My daughter has been diagnosed borderline ADHD, and she hates being on the meds, so we haven't had her on them most of the time. I've noticed that girls with ADHD get in more trouble than boys who behave the same way. Boys will be boys, but girls should be quiet. Wow, speaking to a really important sociological piece here.
Yeah, that's a great question, or more of a sort of comment. But to speak to that, I feel like one of the important pieces, if you have a child that has ADHD, is to make sure that the teachers that are involved are educated about what's going on and what strategies work, because you're right, there is sort of a difference in treatment between genders at the school level. And also, I think there's a tendency to just assume sort of laziness or defiance or something, and not be sensitive to the individual issues, because most teachers are so overworked. And certainly by the time they're at the middle school level, where they see 150 students a day, to be that attuned is very tricky. And I've found, with my own kids, that we've had to really be in a lot of communication through email with the teachers about what's going on around homework and behavior and focus, so that they can be aligned and we can be successful.
Right.
Your point, there are actually two important points in your question/comment. And your point about gender is very well placed. There's some really interesting studies actually done in school settings about how teachers differentially treat girls and boys. And it is absolutely true that teachers treat girls and boys differently. And even teachers, who, as part of the preparatory work for the studies, professed profound devotion to ideals of gender equity, and I never would treat my girls differently from my boys. And when you actually sit in their classrooms and observe and count, they call on boys twice as often as they count on girls, even if girls raise their hand the same number of times as boys, right? So teachers, without awareness and without intention, are kind of recreating social constructs and ideas about gender, and it very much, affects how they interpret behaviors, just like it does for anybody else. And that's absolutely true, both for kids, by the way, and for adults, right? Women who have a tendency to blurt out their thoughts in meetings without putting lots of padding words around what they're saying, like, well, I kind of like, right, the kind ofs and the justs and the putting pads around putting their idea forth in a straightforward and direct way, right? Women who do that are likely to be perceived in meetings and at work very differently than men who do that in meetings and at work. And that has a lot of implications for people with an ADD style of being in the world. So I just wanted to make that point. Your other point is also apt about, there are people who really hate ADD meds. And that's a totally legitimate reaction to ADD meds, right? I actually, when people say that to me, I tend to kind of smile, because I think part of what they're saying to me is, I like who I am.
Yeah.
I like how it feels to be me in the world. And I take these medicines and I don't feel like that. And I like to be me. I like how I feel, so I don't want to take the medicines. Okay, great. That's great that you like how you feel and who you are in the world. And so let's just explore other options.
Nice.
And there are other options.
Yeah. And I love that too, because I think that sometimes the side effects of these medications don't get talked about enough. And sometimes taking a stimulant can address the attentional issue, but it exacerbates anxiety. So that becomes an issue. Appetite suppression is a real issue. And I often think, I get very concerned about how this interfaces for people in general, but especially young adults, in relationship to food and body image. And also the side effects related to sleep, and the way being on stimulants, especially if it's a slow release stimulant, can affect people's sleep, which then becomes its own kind of negatively reinforcing pattern, because the reduction in sleep further exacerbates attention issues the next day. So there's all sorts of pieces to the medication, which is, I think, important for people to really understand before they go down that kind of
Absolutely. And the way that you can tell, by the way, so Angelo just made a really good point, that there's different types of medication. One's just kind of regular, and one's called extended release. The non-extended release versions have a pretty short half-life. You take them a few hours later, you're done, they're gone. Extended release versions are present in your body for, a pretty long time, 12 hours or more. And the way that you can tell whether you're taking one or the other is if it has the letters X, R at the end, you are taking the extended release version.
You wanted to come back to the sort of competing neurological theories out there.
Well, I think that this in some ways really informs the treatment of it. And I also just find this stuff really fascinating, but there are a number of competing ideas out there about what really constitutes ADD, or why physiologically this happens, and in particular affecting like a disorder of executive functioning. I think the most popular one is related to the neurotransmitter dopamine. Neurotransmitters are, of course, the chemical messengers that carry signals between neurons, and dopamine is one in particular that works with focus and learning and motivation. So there, we have some of what really encompasses ADD, ADHD, with the idea that people wonder about in terms of the theory is that actually that there's a lower level of dopamine receptors in the frontal cortex of the brain. Now, this pairs with why treating it with stimulants may be helpful, because we do know that stimulants increase the uptake of dopamine in the brain. So that seems to add some validity to this theory. But it also, I think, highlights why there is such a close relationship between ADD, ADHD, and addictions, and why it's so easy to self-medicate with alcohol, with marijuana, with cocaine. These are some of the top things that people can often gravitate to in terms of trying to self-medicate these kinds of things. And then there's other kinds of theories around the size and the density of the frontal cortex, that people with ADD might have smaller regions of the brain, but also could be part of the reason why there's a tendency for half of people that are diagnosed with ADD as children actually outgrow it. I think there's statistics that 9 to 11% of kids are diagnosed with ADD, which is more than 1 in 10 if you think about it. Whereas with adults, I think the earlier slide said 4 to 5%. And this could suggest that as the brain develops, these regions kind of fill out more for some people. And then there's other theories related to the locus coeruleus and how underdevelopments in that region of the brain impact the norepinephrine system, which taxes and strains the ability of the frontal cortex to be engaged in sequencing and decision-making and impulse control and those kinds of things.
Wow, I got so blown away when you said nucleus coeruleus that I lost my next question. that was amazing. So my next question was actually, it was about neuroplasticity and that idea that, hey, if we just practice, then our brain is going to wire this stuff. How does that play into these sort of conditions that you're talking about that seem like they may be a little more permanent?
Well, I think that there is a lot of exciting research around that, especially in regards to why I think mindfulness is an important strategy in working with ADD, ADHD. That's not to say that I think sitting meditation is the best mindfulness practice for these things. But what we do know with mindfulness practice, and a lot of the research coming out of the University of Wisconsin validates this, that there's a thickening in the gray matter of the frontal cortex for people that are engaged in regular mindfulness practice, as well as increased production of GABA, gamma-aminobutyric acid, which is an inhibitory neurotransmitter. It helps with anxiety levels in the limbic system of the brain. So there are some real practices, lifestyle practices that people can engage in that I think can benefit people with this kind of condition.
Okay.
I also want to take a moment to talk about neurofeedback.
Nice.
Yes, because you kind of alluded to stuff that might connect there. So neurofeedback, if for those of you who don't know, is a form of biofeedback, and biofeedback is the process of measuring a physiological activity of the body, showing that information back to you so that you can learn how to change that particular physiological measure, right? So the classic example of neurofeedback is learning to, on command, raise the temperature of your right hand by 2 degrees, But it turns out, if you can learn to raise the temperature of your right hand by 2 degrees, this has an effect on the severity and frequency of onset of migraine headaches, right? Because you've learned actually to do things with your blood vessels, which are implicated in migraines. So, so neurofeedback is a form of biofeedback, which is learning about a physiological activity of your body, and a neurofeedback, which is the research is coming back strongly in favor of neurofeedback as an effective intervention with ADHD.
Absolutely.
We're finding actually efficacy levels as high as or higher than methylphenidate as a treatment. The American Academy of Pediatricians gave it their highest level of support for evidence-based interventions for ADHD. And so neurofeedback is connecting electrodes at the scalp, measuring the activity of the brain, showing it back to the person so that they can learn voluntarily to change the way that their brain is behaving. Right. And one of the coolest things about doing neurofeedback with people with ADHD is that they really truly did not know until they get the immediate feedback on the screen and learn to change it. They will tell me, I hadn't, do normal people feel this way? That's what they say to me. They say, I had no idea that it was possible to feel both calm and focused at the same time. I have to choose one or the other in my ADD style of being in the world. But by learning to get that immediate feedback, they learn, I can do both. And that becomes an option in the behavioral set.
Nice. So, well, and I've used the HEG headband for ADHD with I don't know, like sort of adolescent, pre-adolescent kids, and the so that's measuring the cerebral blood flow.
Yes.
And the interesting thing that happens is because they can see it in real time on the computer, they can't fake focus.
Right.
If they're like, yeah, I'm focused, I'm doing my math. It's actually like we have a biological measure, and that helps a lot with we'll do like school-based stuff while having them wired to just see like how often is the brain getting off task. Can we help that CEO stay a little more focused by having some immediate feedback?
Right, it's kind of poking the CEO, like wake up, no napping. And it, to your original point, right, that part of what we do with that is wire new neural pathways, right? Learn a new behavioral set.
So can anybody make their hand raise in temperature 2 degrees? Is that like
in theory, sure.
In theory, okay.
Yeah.
All right. Try that at home. That's homework. Oh, I just love this slide, so I put it in there. I don't even know if there's anything we really need to talk about with it, but I was a little ADHD when I was making these slides. So
there you go.
Right? Like, isn't that? I don't know. That's just a fun one. Moving on. Now we're really digging into the different treatment options, and I know we just spoke to neurotherapy. What other things have you guys felt like have worked for your clients, or you think for adults specifically would be most helpful?
I think starting with education is really very, very important, because there's such a tendency for, especially with adults who are trying to manage ADD, ADHD within the context of family and spouse relationships. It's so important for the people that are in that person's life to really understand that this is a condition, that this is not in any way indicative of a lack of caring or impulsivity or being irresponsible. Those are really mischaracterizations of what's going on. And it often happens between spouses where they're talking to their partner who has ADD, and the person starts to zone out, and it's really easy to feel like they just don't care. They don't care about my day. They don't care about what's happening. When in reality, I think it's important for spouses to understand that this is really a very different way that the brain is working. And again, like I think Dr. Sunda's metaphors with the coins are really very helpful in order to help them understand what the context of what's going on. Because otherwise, it's very easy for the family system, for spouses to begin to act and respond and react in ways that actually exacerbate the condition rather than help. And then from there, I think education with the person who's suffering from it in particular is helpful to really address that this is a way their brain works, there are benefits to it, and that there are ways of managing it both that include medication, but also include really looking at exercise and diet, and there are strategies that can really help the situation out.
this is a great follow-up question about spousal support. Rather than, in this case, educating the spouse that does not have ADHD, that spouse has declared that this person has ADHD.
Yeah, I had the idea that you could diagnose them with attention surplus disorder.
There you go.
Which is a whole other
ASD.
diagnosis. Yeah, ASD.
Attention surplus. I like that. Yes, right. Okay, so the question is, my spouse has decided I have ADD. He's very organized and detail-oriented and doesn't understand anybody who isn't. Okay, so having a different preference for levels of organization or detail orientation than your spouse is certainly not sufficient to qualify for a diagnosis of ADD, although there might be some couples therapy work to do there. Yeah, so I also wanted to just really reiterate and reemphasize Angelo's point, which is education can be so helpful, both to the individual and to the family system, just in terms of understanding what the style means, the implications of it, and some potential strategies for dealing with it effectively.
Yeah.
And there's 2 great books, by the way, that I find really helpful, and those are called Delivered from Distraction. The same author also wrote Driven to Distraction. That's an older book. And You Mean I'm Not Lazy, Stupid, or Crazy are both 2 kind of classic resources that people sometimes find very helpful in terms of getting some basic education about the dynamics of ADD.
Dr. Hallowell.
Yes.
He is a phenomenal speaker too. If you ever get a chance to hear him speak, he's somebody who is just very charismatic and shares this information really well. So we're getting some questions, I think, related to diet, which is an important one to address, along with some other lifestyle pieces like exercise and psychotherapy that can really help with this.
Yeah, your point about exercise, there are some really good studies out there that say that exercise can be as effective as medication in some cases in helping people regulate attention and mood.
Right.
So, to me, it's a frontline intervention.
Right.
What are you doing for exercise?
Absolutely.
Right. And okay, so asterisk, we live in Boulder.
Right.
Right. Exercise does not have to mean that you're training for the Ironman.
That's right.
Right. Did you go outside and walk for 20 minutes? Fantastic.
Right.
Right. So exercise can be a very wide range of things, but it should be in the plan.
I totally agree. And it can be as little as, I think, 20 minutes of cardio has been shown to be just as effective as stimulants for ADD.
And just, a note about diet, the ways that I feel like people get off track on diet are if we're eating either for taste, which is kind of attractive, or to kind of rev up or sedate ourselves. And if we're looking at how that affects somebody who has ADHD, the revving up with, sugar, caffeine, that kind of thing, or the sedating with like heavy carbs are both kind of common strategies to sort of manage that cycle of energy. And if we want to get out of that because it kind of exacerbates it over time, then we really do want to look at like, how do we simplify our diet and think more about long-term sustained energy and what is fuel for our body instead of what messes with our spikes up and down or what's going to just taste good, right? We've got to start to see food as fuel.
Exactly. Yes. And I think like this is one of those things that runs smack into the SAD diet, the standard American diet, which is which is very apropos because it is highly inflammatory. You get a lot of refined flour, you get a lot of sugars that do create those spikes. And people with ADD, ADHD do have a tendency to have more sensitive systems, and they need to be much more careful about the fuel they're putting in. We want to reduce the kinds of spiking that's occurring. And that's where I think really working with whole food, plant-based diets that allow for longer energy dispersal over time can be really helpful for balancing out those spikes and troughs in energy.
Oh, I was going to say something and I lost it.
I got a question.
Okay.
I'm wondering if you guys could speak to the stimulant versus non-stimulant meds. And
sure.
Oh, I got it back.
Oh,
sorry. I was just going to comment really quickly that in addition to your points, right, there are some pretty good indications in the research that ADD brain is actually more responsive to reward than other kinds of brains, right? So this has a lot of implications in terms of eating for taste, eating for reward, eating for energy bursts, short-term energy bursts.
Or that kind of addictive energy of just sort of like the immediate gratification.
Yes, right. It's more rewarding to ADD brain than to non-ADD brain. So that just has some implications in terms of making careful choices about food. I also want to just note really quickly, I have heard some theories about diet and ADD that it's food dyes or it's, there are some other things implicated, and that I know of these theories have not really been borne out by the research.
Mm-hmm.
There is a lot of really compelling research going on about inflammation and how that relates to food. So, but that's probably a whole nother webinar.
Nice. So Angelo, you're about to help us out with the stimulant versus non-stimulant meds.
Well, I'm not sure how much about it I can really say beyond, there's obviously a whole class of stimulant medications. Those can include things like Concerta, Focalin, Vyvanse, Adderall. And then there are ways where ADD is treated with Strattera. Strattera is a non-stimulant based medication. It works more on the serotonin pathway in the brain. So it actually functions more like an SSRI. But those are two big distinctions in terms of how ADD is typically worked with from a medication standpoint.
Can you say, like, if it's an SSRI, why aren't we diagnosing somebody with like a mood issue as opposed to ADHD?
Well, it's a good question. And I think, again, I mean, this is a piece that we were talking about earlier, that I think that there can be so many different mood components to it, and why I think some psychiatrists actually wonder if treating ADD with SSRIs is a valid treatment in any way, especially with something like a Wellbutrin, which does have some stimulating effects, but is not necessarily a stimulant. But again, this is where I think the more comprehensive an approach that we can take beyond medication, the better we're going to do at really approaching this in a multi-pronged kind of way and in a sustainable way for people. So I think medication is often a part of these conversations, but I often want to really bring it to broader, more lifestyle components of how we can approach this in a variety of different ways.
Nice. A follow-up on that, what's the trajectory of trying to determine medication's efficacy? So if it's time to say, okay, I want to try a non-stimulant, how do I know if it's effective or not? Because I feel like a lot of times, maybe in the first couple of days, we sort of overemphasize whether we feel good or not as to whether or not that med is effective. And I feel like a lot of times, boy, like the course of the ups and downs in our month might take a while to really sort of.
Sure.
What do you think is the road for people if they're going down the medication route? What should they be prepared for?
In terms of checking back in with their prescriber?
Mm-hmm.
Yeah.
And the duration until they get to some sort of efficacious treatment.
That's a good question.
I said efficacious.
Efficacious. I love that you
Efficacious
use the word efficacious. But I that's where I think really, I think combining psychiatry and psychotherapy can be so beneficial, because I think a psychotherapist that's meeting with a person on a regular basis and really monitoring how a person seems to be adapting to a medication can be very, very helpful. And then from there can really work with the person to decide, is it time to see the psychiatrist again, either to augment what's occurring or to validate that, yes, this does seem to be helpful. But med changes are very, very important. They can have all sorts of effects. So I think sometimes having more eyes on a person as they go through that process is beneficial.
Nice. Okay.
One of the other things I just wanted to say that I do think it's important, psychotherapy is a very valid and important intervention for ADD, because it's often the case if a person has been struggling with ADD throughout their life, that means that they're also likely struggling with self-esteem and self-confidence issues. They've been told they're stupid, or they've been told they're irresponsible throughout their life. It's often led to relationships falling apart, so there can be trauma components. And there are just all sorts of things that can really add up to be impacting a person beyond just the ADD. So having a therapist that can be addressing those issues with relationship, with decision-making, with self-confidence, with trauma is very, very important, whether that's CBT, Rogerian, psychodynamic. I just think psychotherapy and ADD are really two important. It's a very important way of leveraging and working with ADD.
Nice. Yeah. I like this slide. It reminds me of sort of the coaching support that we can get for adult ADHD, which is more about day-to-day management strategies, little tools that we can use, how our environment supports or inhibits our success. And I can certainly relate to this one. In fact, like just this past week, I lost my glasses for like an hour and a half, and the insanity of my mind in that moment, right? Like the chaos when we're not organized, or when our CEO is like overwhelmed or something. It's just very frustrating, right? And to be able to settle down in those moments where we are in that state and something seems really important, I think is tricky. Yet probably if we're dealing with ADHD, it's going to come up enough that we want to have a strategy for those moments.
I just want to point out, we just got the 5-minute warning, so I'm passing the 5-minute warning on to you, our lovely listeners. So if you do have questions, please get them in now. We will be wrapping up in about 5. And we would love to answer your questions.
So here's another list of more of those self-management strategies of just how to kind of keep your life functional, organized. It's more from that coaching approach than therapy or the medical route. But I think all these things are really helpful too as part of that comprehensive approach that you're talking about.
Right. And I think deadlines in particular, I would just highlight. I think having a time boundary can be very helpful with people with ADD, ADHD, in part because oftentimes people are running off of more adrenaline than they are dopamine. And having a sense of coming up to a time boundary can be very helpful to spark a person with ADD, ADHD into action, kind of like Dr. Sunda was talking about earlier, in terms of initiating an episode of hyperfocus where they know that paper is due, or they know they've got to get that report into their boss, and having a very clear deadline can be very motivating and helpful to actually getting the project completed.
And one of the ways that I sometimes talk about that with people, right, is if your CEO tends to be a napper, right, your CEO is drinking on the job, you've fallen asleep. So we try to rely on our CEO as our breaks, right, to stop paying attention to things that we shouldn't be paying attention to and pay attention to what we should be paying attention to. CEOs asleep, sometimes it's really helpful to find strategies for external compensatory mechanisms, right? Okay. So if CEO forgets to put on the brakes or divert resources, are there ways that we can externally compensate for sleepy CEO, right? So breaks, external breaks, right? Like a well-kept time management plan, right? That will create deadlines that are external to CEO who's not really on the job right now. So those kinds of external compensatory strategies.
Well, and as you were talking, it was reminding me of the setting those little alarms to go stretch or go take care of whatever task, and to have that tool that is available now with technology so easily, because our mind doesn't really manage that stuff very well, even if we don't have ADHD.
We are getting a comment saying living in Buddhist monasteries with external locus of control was most helpful for me, which makes a lot of sense to me, right? Yes. In fact, one of the things that you sometimes hear is, I joined the military, right? Massive amounts of external compensatory mechanisms going on, right? You will show up on time or there will be a problem.
Well, I think it speaks to the idea of imposing structure on ourselves when the world isn't doing it, because like that beginning of setting up money management, bill paying systems. Yes. I feel like anything that's repetitive, if we don't just at some point go, all right, how do I want to deal with this in general? What's my strategy? Then we're constantly reinventing the wheel and having sort of nothing to go back to as our subroutine strategy that our mind likes. We like doing those things that are sort of repetitive. It's time to brush our teeth, time to put our shoes on, time to drive to work, whatever it is. That task is kind of cool. And whatever these things are, they're sort of logistically hard, the executive functioning routines that keep coming up. If we can take some time to actually plan out what's the right way to do this if I'm on my game, then we can have that going for us.
And I think that speaks to it really helping reduce the amount of decisions that a person with ADD is having to make. The more decisions a person's having to make, the more the CEO is going to go into nap break. Whereas if a routine is just, okay, this is the next thing that needs to happen, this is the next actionable step, that's very, very regulating and motivating for somebody with ADD.
Nice. We're about to wrap up here. I want to thank you all for listening in. We're going to be sending out a link to this video that you can see through our website or on our YouTube channel, Boulder Psychological Services. And I especially want to thank Angelo Ciliberti and Dr. Sunda Friedman TeBockhorst for being here today. They are the experts on this, and I'm sure you guys felt that the way I did too. It was a pleasure to be presenting with you.
You forgot somebody important in the expert group.
I'm Dan Fox. Thanks for listening.
There we go.
There we go.
Thanks, everybody.
Thanks, guys.